welcome, welcome, welcome to Health Issues. I'm your host, Chris Sylvain, and this is an exciting show. You know, we're always excited to talk about health, nutrition, and this time we're actually going to speak particularly about diabetes, and a major issue. We have an awesome guest for you, comes from a great institution, the Pennington Biomedical Research Center. We have Dr. Daniel Hsia. Welcome, Doctor. How are you today?
Very good. Thank you.
We're excited to have you. You know, we just love it. First, where we were right before the cameras came on, let's talk about this. You're a Louisianian, now, Jesuit.
Yes. So born and raised in Thibodaux, so I'm a local Cajun boy. But
Boudin.
That's right. That's right. But went to Jesuit here in New Orleans, flew the coop for college and med school in upstate New York, and then wanted to come back and give back after medical school. Came back to do residency here at LSU and at Charity Hospital right around the time with Hurricane Katrina hit.
Really?
And so I went through all that and had to really move and finish my training in Houston, unfortunately, and so did that for 4 years at Baylor College of Medicine and Texas Children's Hospital, and so got a great education, and just Louisiana called me back, and you know, I'm really interested in prevention and treatment of diabetes and obesity, and these are serious problems in our state. And what better place to work and to do research than Pennington Biomedical Research Center right here in Baton Rouge. And you know, as a Louisianian, not really even knowing that place was there for so many years. And it wasn't until I was looking around and I got recruited to come back home, and I got to work under Dr. William Cefalu, who's the center director, and he's a true pioneer in the diabetes field, and an editor of the largest diabetes, journal in the country, Diabetes Care, and so it's been a real, it's just a real pleasure and just lots of fun to work at Pennington.
Well, I always look at Pennington almost like you have all of these academic superstars come through there, like Cefalu and Dr. Bray we talked about earlier, and we see you coming right along in that vein, huh? Halfback, football player. That it's exciting because it's helping people. Because I was just looking at something. I don't remember the source, but the new surveys on obesity is that it is increasing.
Right.
And New Orleans fits right on in there.
Absolutely. And
to where almost, is it 40% of females are obese at this point?
Yeah, that's right around the number. Just looking at overweight and obesity, it is. I mean, you're talking close to moving towards that 50% mark, and so with obesity comes all the cardiovascular problems, diabetes, high blood pressure, high cholesterol, and so in Louisiana in particular, it costs the state over $5 billion just in lost wages, medical costs. So if we don't curtail this, this is just going to be an astronomical problem in the coming years.
Okay, let's do some basic stuff. What is endocrinology?
Okay, so endocrinology is the study of hormones and how those hormones affect the other different organs in the body.
Okay.
It's one of the few specialties that you really got to know multiple different organ systems, because diabetes could affect the kidneys, could affect your eyes, can affect the nerves, and so it's one of these sort of comprehensive specialties, and that's what I really enjoy about doing endocrinology.
Okay, so you guys, but diabetes ends up being a major focus. I know for your work, diabetes is focus. But one of the key things, this concept of diabetes and prevention. So people, regardless if Mama, Daddy, Uncle Joe, and Uncle Fred had it, you can prevent diabetes.
Sure. One of the largest studies looking at diabetes prevention was called the Diabetes Prevention Program, funded by the National Institutes of Health. We enrolled a couple of hundred people at Pennington Biomedical, and that study was really a seminal study to say, you know what, diet and exercise over a pretty good period of time can really halt and prevent the development of type 2 diabetes. Up to almost 60% of the population that lost on average 5% of their body weight, and did that with physical activity, different nutrition. They were able to prevent the onset of diabetes. And right now in 2016, that sounds, well, of course that's going to do that. But 30 years ago, we really didn't know that. And so to do those types of studies and to really say, once and for all, this is what we need to do. These are the types of parameters, the amount of physical activity, the amount of weight you need to lose. Those are the types of things that we're finding out from these studies. So.
Okay, we're starting to see kids younger and younger.
Sure.
All right, with type 2 diabetes.
Right.
All right. Explain what is really going on
Absolutely.
compared to, say, 20 years ago.
Yeah, so in the last 30 years or so, the rate of type 2 diabetes in children has gone up nearly 30-fold. And that seems to be driven by the obesity epidemic in children. And although the last couple of years of statistics may say, well, it looks like maybe things are kind of leveling off, when you break down the numbers, the group of children that are what we consider extremely obese, so these are the kids who are, their weight is greater than 120% of what they should be, that actually continues to rise. And so that seems to be driving the rate or the increase in type 2 diabetes, because in that age group, you really don't see children who are in the normal BMI range developing type 2 diabetes. It really does seem to be driven by the excess amount of weight and fat that some children are developing. So,
well, let's help some people.
Okay.
Okay. All right. What do people need to do to reduce the weight or to stop the weight
Sure.
from coming on?
Right. Well, from a pediatric standpoint, so from a young child standpoint, it can even start as early as in utero during gestation, and we have studies going on at Pennington trying to understand women that gain too much weight. What are those effects on the baby? Because it seems like moms who develop gestational diabetes, their child has an increased rate of developing diabetes in their lifetime, up to a rate of 30, 40, 50%. So you've already sort of behind the 8 ball when you're born. And so even that early on, trying to understand sort of what can we do. But then as the children are growing up, early childhood nutrition, physical activity, making sure that kids are being physically active at least an hour, a day, and then as they're growing up and then going into adulthood, making sure again the physical activity. The recommendation from the diabetes prevention program was 150 minutes of exercise, per week, as well as if you already are overweight or obese. Trying to not lose 100 pounds, it's 5 to 10% of your body weight can really have a difference in your metabolism and your risk for diabetes. So.
Okay, and I know, but as far as for losing weight concerning the foods that
Sure.
we eat, if you can just grab a hold to that, I think a lot of people they're sitting at the edge of their seat saying, all right, good, I need to lose 40 pounds. How am I supposed to do this?
Well, it's still we still trying to understand what are the best diets. We hear about the fad diets, removing things out of your diet, so the so-called paleo diets or sugar busters or things like that. And anytime you remove a whole food group, your body has to compensate somehow. And as soon as you go back to a regular diet, your body is almost starved for that particular type of what we call macronutrient. So that weight even goes back up, and sometimes people gain even more weight than from where they started. So it's really looking at calories. We actually were involved in a trial called the DASH diet, which was rated the #1 diet by U.S. News and World Report, I think for 5 or 6 consecutive years. That's a diet that's been shown to help people with high blood pressure, and it also seems to help people lose weight. And so latching on to that is a potentially, now that's a diet that's been really studied pretty hard. But still, I mean, little things to cut calories out of your daily, routine. Switching to, if you're used to drinking whole milk, switching to 1%. That's a huge calorie difference. If you look on the label, I personally counsel my patients. It's not, it's not about what you can't do, right? Because people are always going to be focusing on you can't eat this, you can't eat that. Throw that food away, put that, get that out of your cabinets. It's about how much can you eat of this particular food. Because if you eliminate things out of your diet, you just want it more. That's sort of human nature, and so you look at, and I think getting a consultation with a dietitian or nutritionist is a really good idea and is a good start, because they can look at ways to substitute things and ways that you can cut calories out of your diet. So we don't recommend these real crash diets. We really want you to only lose about 2 to 3 pounds a week, and that's sort of a safe sort of weight loss, so that by a year's time you can get to your ultimate goal. So
pretty good. 2 pounds a week, 52 weeks.
Yeah,
you do a lot. You do a lot. Well, let's talk about this idea of insulin resistance.
Sure. Okay.
Tell me what that is.
Well, so what insulin resistance, what it boils down to is, your body is not using the insulin that you're making. Your body makes insulin, and so that's what's needed to get the food and the specifically the carbohydrates that you eat into your cells. Your cells have to, they work on they need energy. And so if you're insulin resistant, all the foods and things that you're eating don't get into the cell, and your cells actually, they don't function as well. And so being insulin resistant causes your pancreas, which is what makes insulin, to really kind of be in overdrive and pump out more and more insulin. And so that higher rate of insulin causes you to be more hungry. Because you're hungrier, you're eating more food. So it's kind of, you get into a vicious cycle, and all of that is almost directly related to weight gain. So as you gain more, you gain more fat. You gain fat cells. And we can talk about fat, where the location of fat, how the importance of that is. But just in and of itself, the weight gain basically causes the insulin resistance, and because your body has to process that much more of the food that you're eating. So,
so insulin makes you hungry.
It can, absolutely. It does. It does.
So people get on insulin and they gain weight, and then they need more insulin.
They do, right. So there are certainly people that are first started on insulin. That's one of the, let's say complaints, but I would say side effects. They become hungrier, they feel like they need to eat more, and so you do have a little bit of weight gain as you're starting insulin. But a lot of times those people have unfortunately lost weight, because if your body is not able to process the food that you eat, you're basically going to be urinating out all that sugar, and that's one of the main symptoms when you're looking for people that who should we check for diabetes? Well, people are drinking a lot of water, urinating a lot, getting up in the middle of the night. That's because that's where the sugar is ending up in the urine, and so that's sort of the bottom line with insulin resistance.
Well, in Pennington, you guys are doing a whole lot with this concept of diabetes. But you mentioned earlier, we can, having diabetes is almost like having had a heart attack.
Yes.
As far as for your risk of having another heart attack,
absolutely,
or a risk of sudden death or whatever. What's actually going on here, where diabetes is allowing the plaque to build up faster,
right.
What's really going on?
Well, so yeah, we don't know 100%. I mean, there's always research going on, and it's a better understanding who develops complications, who will end up having the heart attack or the stroke from the diabetes. But ultimately, what we think it is that yes, the high sugar ends up damaging the lining and the vessels, and when you get damage in the lining of the vessels, your own body actually starts to cause inflammation, and that inflammation basically causes the potentially some thickening of the arteries. And when you have that, you can have a heart attack from that, or a stroke. And so that's why it's real important that we treat the diabetes as best as we can, as aggressively as we can. We have studies at Pennington that are trying to better understand what are the best treatments for diabetes. In particular, we have a large National Institutes of Health funded study called the GRADE study, and we're looking at 4 different medications added on to metformin, and we're recruiting right now for participants. We're still going to be recruiting for another year, and so I encourage people that are watching this, if you have diabetes for less than 10 years and you're taking metformin, give us a call at Pennington. It's a real, it's 225-763-3000. You can just go to our website, www.pbrc.edu/healthierla, and you can look at the various clinical trials that we're doing, trying to basically treat diabetes the best that we can.
But metformin is solid. Metformin is good for everybody.
That's
if they can stomach it.
If you can stomach it, that's correct. So I think there's about a 20% or so of people that just can't tolerate metformin, and for whatever reason, and it's usually because of it gives them stomach upset and things like that. But metformin is a pretty tried and true medication, and it's been used in long-term studies. So we have a lot of studies, even in the diabetes prevention program. We actually have people now on 20, 30 years of metformin, and so it's a very well-studied drug. But unfortunately, we have more and more drugs coming to market, and unfortunately, you see a lot of side effects of some of these drugs, and people get concerned. Well, which one is really the best one? So we at Pennington have studied every class of diabetes medication on the market. So we have directly contributed to getting some of these medications in the hands of people who really need it. So.
Let's talk about these other 4 now. What are the other 4 that you're putting along with them? Because we hadn't come up with a better metformin yet.
That's right. That's right. Yeah. So in the end, as people go on with diabetes, it's a progressive disease. That's another thing that most people don't realize. Yes, you can regress and develop and get off of your medications if you lose weight and change some of your habits. But for the most part, a lot of people, unfortunately, it becomes progressive, and you need to add more and more medications to your regimen. And so the 4 drugs we're testing are, and again, they're all FDA-approved medications. One is a type of insulin called glargine. Okay. One of them is a medication called glimepiride, which is a tried and true medication. Right. Another medication is called liraglutide, which is what we call a GLP-1 agonist medication. That's just that's a fancy class drug. And then the last one is sitagliptin, which is a DPP-4 inhibitor. And so some of these medications may sound familiar to some people because they might already be on them, or you may have seen them on TV. But this is the kind of study where nobody is getting a placebo. Everyone's getting treatment, and we're trying to see which combination will or basically how long will it take for someone's hemoglobin A1C, which is a marker for their blood sugar control, how long will it take for them to reach a certain threshold, and which combination unfortunately fails the quickest. And so that would be one that we wouldn't necessarily want to put people on in the future. So.
It's amazing. In 2016 we're doing this study.
That's right. Well, it's unfortunate because I always tell people this. You ask 10 doctors, what should we prescribe? You're going to get 13 answers. Right. So it's unfortunate, but that's the world that we live in right now. And it's very interesting. We mentioned all the research. The American Diabetes Association is in town. It's having their annual meeting. It's the largest meeting in the world dedicated to diabetes care, research, and so we're hoping to learn more in the coming days. Actually, just going to that conference. So.
Well, as an endocrinologist, multidisciplinary.
Yeah.
One thing you said, we talked about the prevention of diabetes.
Sure.
But we also talked about the progression of diabetes.
Right.
Disconnect. if you can prevent it,
right,
as an endocrinologist, you can tell them, look, this is your prescription.
Absolutely.
Follow the program. Do as we say.
Yes.
You know what I mean?
Right.
Do exactly what we tell you to do.
Yes.
And your diabetes will go away like Casper the Friendly Ghost, and you'll be great. Or you won't get it. Just follow the program.
Right.
But people don't follow your prescriptions.
Yeah. So that is that's difficult because in my practice, I'm always looking for, what is your motivation? What is your motivation to improve your health? Is it because you have family members that may have had diabetes, and you've seen some of the bad complications that has occurred with those family members? Is it because you just want to be healthier? You have a family that you want to live for. You want to just want to feel good. You don't want to feel tired all the time. You don't want to not be able to do the things that you want to do, and you want to live a full and happy life. I think you just need to find the right motivation for each individual, and so that may take time. I mean, it may take several visits for the light bulb to go off, so to speak. And so that's why it's real important to see your physician regularly, to see your the nurse practitioner, physician's assistant, dietitian, whoever you feel like you have a connection to, who can really help be your coach, champion, to help you along. Because I always tell people, it's not, I can't go home and make you take your medication, or change your diet, or take you and take you to the gym. It's really up to you. And I think once that change is made, I mean, I have seen just remarkable stories of people who come to Pennington, who are in some of our weight loss programs, diabetes prevention programs. We've reverted their blood sugar back to normal, taken them off of their medications for high blood pressure and cholesterol, and I mean, those are individual success stories. But I think if we could put that out there, I think we can help a lot more people. So and again, that's why it's so important to be doing the kind of research that we do at Pennington.
Okay, I got to ask this. And you've studied history, Jesuit man and Baylor and all these places. Okay, we got it. Jesuit, Okay, anyway. But medical care, medicine, for years, the physician had control over the patient. Okay. Because the nature of the way we saw disease was that just follow the program. Right. But now, since we're understanding diabetes to be more of a free will lifestyle issue, not genetic, as we say. I mean, the genetic propensity, it's not like it's meaningless, but if you can prevent it, it can't be all that great.
That's right.
So that means the power is in the hand of the patient. And I'll throw this out. Okay. Has medical care caught up to the way the basic scientists have now taught us to understand disease? Yeah,
so I think that's part of the reason why in the beginning of medical school we have all that sort of basic science and physiology, and if you don't understand sort of the building blocks of what makes the science go, what makes the treatments work, then it's really hard for you to tell your patient, to advise your patient. I think that nowadays, and really, I feel like I'm, in another generation. I'm sort of an old generation now, and I don't maybe a new generation of doctors coming up, but I've sort of seen it sort of transitioning in from both sides. When I first started, it was definitely a lot of, you should do this because I told you to do that. A very what we call paternalistic type of medicine. But nowadays, I think it's more of a team approach. It's more of, I am sort of going to help you, and we're going to do this together, and not so much a lecturing and not so much a sort of a parenting kind of approach. And so I think medicine is catching up. I don't know if it's 100% there, but I think that the more people are aware of their disease and their condition, I think the better it is in order to treat them. The better understanding that they have, I think that the better they understand your treatments. Some patients will come in and they'll teach me. I mean, hey doc, did you hear about such and such? And I said, well, actually, I haven't heard about that. I'm going to have to look that up. And so it also drives the physician to stay on top of things and to stay current, and that's part of the reason why I like doing research, is because I try to be on the cutting edge as much as possible. So I think that, yeah, that's sort of where medicine is today.
Awesome, awesome. We have a couple of more minutes and questions. I'm excited about this. Just bringing forward some good stuff.
Great.
But you said something, the awareness of a patient. I believe that, so I'm totally biased. So I'm gonna just throw it out there that we're not dealing as much in willpower as awareness.
Right. Yeah. Sure. So. I mean, willpower is important because that willpower will help you sort of in that individual situation. Make two different choices. Am I gonna go and maybe splurge and have a high calorie meal, or maybe I can make a different decision and eat something a little bit healthier. But awareness kind of is more global, and so the awareness of how why you're having to take this medication, how can you improve your well-being. I think that is sort of an overarching kind of thing that all patients, I think, should be more in tune to. So,
and your job is to get them aware.
That's right. That's right. Absolutely. Yeah, that's part of the physician's job. Absolutely. So I consider myself as much a teacher as a physician. So.
Coach.
Absolutely. Coach, yep.
All right, Coach. Let's take a few minutes, and you got a few people listening to you. You can give them a 1-minute pep talk on what they need to do to prevent diabetes and get rid of it.
Okay. All right. Well, first and foremost, I think need to be, when you talk about awareness. So if you have, if you're not feeling well, if you are, experiencing symptoms of, having to go to the bathroom frequently or feeling thirsty all the time, get yourself checked. Go to your doctor, go to your local healthcare provider, and just be screened for diabetes. The recommendation that came out last year was that if you're 45 years and older, you should just be screened for diabetes. Period. I mean, no ifs, ands, or buts. Forget the other risk factors, because it's so prevalent. 1 in 10 people in Louisiana have type 2 diabetes, and so so if you don't have a family member, you probably have friends or other relatives with diabetes. So I think again that's number one. And then in order to prevent diabetes, think about getting some assistance with, getting a nutritionist, talking to your local gym or whatever the local fitness place is, and sort of be involved in your own health, and know that there are things that you can do about your own health, and potentially come to Pennington, participate in one of our clinical trials. You'll find out a lot about your health, and we'll take good care of you.
Hey, it's Dr. Daniel Shaw, Pennington Biomedical Research Center. He already gave you the prescription. Just do the program. Thank you so much.